Hello, everyone. Good afternoon, and we're going to get started now. I see that we have about 55 people on the line, so that's a good turnout, and I hope everyone can hear. On behalf of the Joint Health Equity Group of the Ontario Public Health Association and the Association of Local Public Health Agencies, I want to welcome you to this webinar about the health of urban Indigenous people in Ontario. My name is Julie Hill, and I'm a social determinants of health public health nurse with Region of Waterloo. Working to improve health equity for Indigenous populations has been a goal that the Health Equity Work Group has been working towards for quite some time. So far, this work has resulted in several educational offerings, resolutions for action that have been passed by both OPHA and ALPHA, and the influencing of other public health initiatives such as TOPIC. So just a couple of notes. Your devices have all been muted. To interact with our speaker, myself, or our technology guru for the webinar, please write your comments and questions into the chat box, and we'll respond to them in timely fashion. Also, you can see what's on the slide there. You know what we're doing here. Just to review, we did set some goals for this webinar, and hopefully we will meet all those. And slide 3, our lovely Ontario, satellite image. Let us just take some time to acknowledge the land which sustains us all, and to acknowledge the original people of this land, who today are known as the Algonquin, Mississauga, Ojibwe, Cree, Odawa, Potawatomi, Delaware, Haudenosaunee, and Métis. We offer these nations our thanks for sharing these lands they have traditionally cared for. We also acknowledge the Inuit who have traveled to this land and all the other peoples who have come to share in the bounty of this land more recently. We are so lucky to have Dr. Janet Smiley as our leader today. Dr. Smiley is a family physician and a public health researcher. She currently works as a research scientist in Indigenous health at St. Michael's Hospital Center for Urban Health Solutions, where she directs the Well Living House Applied Research Center for Indigenous Infant, Child, and Family Health. Her primary appointment is as a professor in the Dalalana School of Public Health at the U of T. She maintains a part-time clinical practice with Inner City Health Associates at 7th Generation Midwives, Toronto. Dr. Smiley has practiced and taught family medicine in a variety of Aboriginal communities, both urban and rural. She is a member of the Métis Nation of Ontario, with Métis roots in the prairies, and her research interests are focused in the area of addressing the health inequities that challenge Indigenous infants, children, and their families through applied health services research. Dr. Smiley is currently leading many research projects in partnerships with First Nations, Inuit, and Métis communities and organizations. She holds a CIHR Applied Public Health Research Chair in Indigenous Health Knowledge and Information, and was honored with a National Aboriginal Achievement, the Inspire Award in Health in 2012. The Métis woman, Dr. Smiley, acknowledges her family, teachers, and lodge. Welcome, Dr. Smiley.
Thanks very much, Julie, and thanks very much to the OPHA and the Health Equity Group for this invitation to join you again at a webinar. I also put up a picture of the land, so thanks, Julie, for that beautiful land acknowledgement. We're here in downtown Toronto. Grandmother Jan Longboat, one of the grandparents I get to work with at Well Living House, reminded me just the other week about Toronto as being a historic gathering place for many different First Nations. As many of you know, we've got a beautiful lake with many creeks and rivers, and even though there's been some shifting of soils, apparently at the end of one of those creeks was a large tree, and that's where different nations met together to meet in council, to trade, and to share. Julie also spoke about how I like to acknowledge my teachers and elders in Ceremonial Lodge, and today I would especially like to acknowledge my father, Douglas Smiley, who sadly passed away. He lived a long and full life and had a relatively peaceful passing, but I lost him this Friday past, so I'm going to dedicate this talk to him. So just firstly, a couple words about the Well Living House, and then what we're going to do is talk about urban Indigenous health and health service evaluation. So by the end of the talk, I think there's an objective slide somewhere, but by the end of the talk, hopefully you would, I think we had 4 objectives. One would be that you would actually have an ability to know what the actual updated population sizes are and number of urban Indigenous people in Ontario. Another one is to know about some of the key social determinants, health status, outcomes, and health access issues for Indigenous people living in Southern Ontario cities. And then another one is to understand some principles of Indigenous evaluation. And then finally, hopefully you'll be able to apply this to your work. So the Well Living House Research Center that Julie spoke about is an action research center, and it's based at the Center for Urban Health Solutions at St. Mike's. And basically we try actually to do community-directed, partnered, applied health research. And we're lucky because like most things in Indigenous health, public health, the good work, and probably public health more generally, the good work actually builds on good relationships. So there is Jan Longboat, and that's just a picture, actually, one of the things that we're like to share as perhaps a wise practice or a model, though it's scary to say those words in our communities, just like everybody else, because I'm cited in an academic research institute in a Catholic hospital. Obviously, there can be some system issues and everyday issues in terms of doing good work in a way that optimizes the value for the diverse First Nations, Inuit, and Métis peoples that find themselves in urban areas and across the province. But what we do have is a signed legal document, an MOU, between the Council of Grandparents. So there's Jan Longboat there in the middle with the Eagle Feather, Madeline Dion Stout, and Carol Terry, and we're happy that we have a grandfather, Albert Dumont, now, and the senior leadership of St. Michael's Hospital. So that's VP Art Slitsky, Dr. Pat Ocampo, who was the former director of CS when it was C-Rich. So we'd like to talk a little bit about that because we're not aware of any other hospital-based research center that has that kind of agreement. I spoke a little bit about the objectives of that 4th objective, and just to try to keep everybody thinking as I'm speaking, and probably most of you will do this naturally, but hopefully for the discussion, because there's quite a bit of information, I'm going to present most of it at a high level, so some of your questions might be for a little bit more specific or drilled down information, but can you think of one way that you can apply the Our Health Counts findings, and then another way that you could apply some of the evaluation recommendations or principles to your work? Or maybe a puzzle. Maybe you want to apply it, but you see a barrier. So as I mentioned, one of the important myths that I seem to encounter, and we actually see it in the news, in like the majority of provincial and federal health policies around Indigenous health, there's actually a disproportionate or imbalance between, I think, the number of policy tables and resources and where people actually live. So for us as public health people, population health people, of course, the first important thing is how many people are there. And where are they, so we can meet their needs. So actually, the majority of Indigenous people everywhere in Canada now live in cities, and it's the large majority of First Nations and Métis people, about 1 out of 4 Inuit people. In Ontario, so sometimes people think, oh, in First Nations, Inuit, Métis people all live in northern areas of the province or in the prairie provinces, but Ontario actually has the largest Indigenous population of any province and territory in the country. And actually over 80% of the First Nations, Inuit, and Métis people in Ontario live in cities. The other myth is that people think that when Indigenous people move to cities, you just don't have to worry about them anymore. And again, maybe some people know that there are outstanding issues. So obviously there's some kind of policy issues, both past and current, where in particular the federal government had an open agenda, right, to actually encourage the assimilation of Indigenous people. So many federal programs and policies, so for example, there is an Aboriginal tobacco program. They will not serve Indigenous people in cities. So actually I was in a situation 2 years ago where we actually had a number of First Nations, Métis, and Inuit organizations who had developed their own tobacco reduction programs. But when I called the federal government, who actually hadn't expended all its dollars, they said, oh no, we can only do these programs for First Nations on reserve and Inuit living in the north. You'll see in a minute one of the important findings of the Our Health Count studies actually is the rate of commercial tobacco use is actually 3 to 4 times higher than that for the general Canadian population. But anyway, so here we have in 2 of our studies now, which I'll share with you, like 80 to up to 90% of the Indigenous populations is actually living below the low income cutoff. And I challenge anybody on the call, if you know of a single, like First Nations, Inuit, Métis, urban health status inequity that actually disappears in an urban environment, let me know, because I've been at this for a while. And in some cases, things are worse, but I don't know of a single health outcome that gets better. And for me, of course, all of these situations, inequities of the social determinants of health, this policy context which is ongoing, are unacceptable. But to me, it's particularly problematic here in the city where I'm in downtown Toronto. I'm actually restricted in my medical practice. A little bit, mostly so, for example, I'm a staff physician with the St. Mike's Family Medicine Associates, very part-time, but I can't do call because we're in a family health team and there's a punishment if somebody's part-time, right? And you can only have, because you can only have a certain number of physicians. So here we have this, like, overage of primary health care providers or physicians, at least according to some policymakers, but then the health inequities don't improve. So we have linked some of that to actually problems in terms of accessing culturally safe services and actually attitudinal and systemic racism. And of course, that was the topic of my webinar when I did one, I think, 2 years ago. Okay, but today we're going to talk about data and data systems. Okay, so, and again, it's easy to draw pictures, but in some ways, if we looked and thought from a health equity lens about information, so some of you are like social theorists, right? So knowledge is power, right? So when we have socially excluded communities, who carries the knowledge about them, right? And who frames it, who uses it, right? So what we find in Indigenous communities and many other socially excluded communities actually is they don't have access to the data that is actually the data about them. And because it's data about them, in theory, you could actually say maybe it is their data. So for example, I've been working for about 15 years on the Maternity Experiences Survey, a bit of a dated survey now, but actually I don't think we've had another one. So it was a survey, as many of you may know, of mothers in Canada, quite comprehensive. There was actually about 500 First Nations, Métis, and Inuit mothers that participated in that survey. So one could say, okay, well that data how do we have a relationship between that data and those communities? But in fact, if you want to access that data, you actually have to write a SHRC proposal, know how to program SAS, like be able to get access to the StatsCan Research Data Center. So there's quite a few. That external gatekeeper wall is pretty big there. if you just wanted to find out about your data. And of course, this is a very important topic as we become a data-driven society. And now everybody's starting to experience that a little bit more. So here, if we could just transform it, and again, if only it was as easy as drawing a picture, but the example I'm going to give in the Our Health Count studies is our attempt to try to do this. So in theory, if we had health information systems, data systems, what you would want is the community to be at the center, right? But of course, the general person out and about might not be an expert in health information or social justice or health. I mean, they have a lived experience, that's for sure. But what we need to do is find community organizations and representatives then that can provide that governance and management and leadership. And then hopefully, nothing would happen in research, policy, or action unless it had been vetted by those community partners who would make sure it was happening in the best interest of the community. So all of the work that we do at Well Living House, we actually have a contract with the communities, the data work, so, and the communities actually own the data. And I can't, so today, even though, as I mentioned, I'd been through a very sad family time, at 5 o'clock last night, I was emailing my community partners. Fortunately, this data in this talk has been shared before, but if I hadn't gotten through to them, I would have redacted slides. So even though some of it's been public too, my commitment is I don't do these talks until the community's approved. So we're lucky, 7th Generation Midwives Toronto and the Southern Ontario Aboriginal Health Access Centre, the EV, actually last night said they were happy to share this information. Okay, so the Our Health Count studies, there's actually been 4 completed studies now, so we're able to start looking across the studies and seeing some patterns, because in fact when we did the first couple we got quite a bit of pushback and people didn't actually believe, and they were pushing back on the census. You'll see in a minute we actually have an article in the British Medical Journal like that shows that the census is undercounting the Indigenous population in Toronto by a factor of 3 to 4. So actually for everybody on the call, I would suggest that you don't actually use the census counts in urban areas, and I'll explain that in more detail soon. But actually now we're just in the process now of working in a partnership with Kenora and Thunder Bay to develop our Health Counts Kenora and Thunder Bay. So for each one of these studies we have a research agreement, and the community partners share the, are in charge of the data. They're the data custodians. So you can see these different reports. You can download them. The first completed report was Our Health Counts First Nations Hamilton, Our Health Counts Toronto. We actually released those reports at the end of February of this year. So basically, one of the big challenges is finding a comprehensive sampling frame for Indigenous people, because we have the Indian Act and the registry list that is held by the federal government, but in fact, and then of course, like lists of First Nations members, lists of Inuit land claim representatives, and also lists of members of Métis councils and provincial Métis organizations. But really when we think about public health, it's quite interesting because one of the things I like to challenge, why would we use like a list of people generated by like a racist piece of legislation that's 150 years old called the Indian Act? And I'm not just trying to say inflammatory things. Like from a scholarly perspective, if you read that document, it's like racist. It says who's Indigenous and who's not, and has a whole bunch of formulas. So why would we use that as our gold standard for Indigenous identity? To me, that is one source of information about a very important population, but just because in the city somebody marries out, does that mean we're just going to discount all the First Nations children, right? So most of the time when you talk to members of like First Nations communities, those people are still members of their communities. It doesn't matter that because of the Indian Act, they have lost their status based on this formula, which doesn't actually relate to blood quantum or identity or ethnicity, because it's really about ethnicity. It would be quite bizarre. I'm actually of mixed ancestry, and no one's ever told me that I couldn't self-identify, for example, as Irish on my dad's side, right? And there's no complicated formula. Well, maybe somebody can do that after the call. Okay, so here in the cities, the problem is we actually don't know how many Indigenous people there are. We have the census, but you'll see in a moment that our very rigorous estimates show that less than 1 out of 5 Indigenous people in cities is actually responding to the census, which is where the huge undercount comes from. Some of you that are involved in census demographics will know that about 76% of the general population actually should respond to the census once we take into account households and people living in institutions. The research over time has been funded by the Canadian Institutes of Health Research, Ontario Ministry of Health and Long-Term Care. And like I said, we call it community-directed and community-implemented participatory action research. We like the fact that we're using this model in a very quantitative fashion. And then, of course, we link to the Institute of Clinical Evaluative Sciences, so that makes it also we have the opportunity to link over time, so we can do longitudinal cohort analyses. And of course, like most things, nothing good happens without many partners. So you can see quite a number of partners. If you look at the bottom of this slide, you'll see the original Our Health Counts, from which 2 of the studies were generated. Our Health Counts Ottawa Inuit, which we just released the report in December, and we're just responding to some requests for revision, but hope the paper will be published within the next couple of months. And the partners were Ontario Federation of Indian Friendship Centres, which actually led the whole project, Ontario Native Women's Association, Tunga Sabinga Inuit, and Métis Nation of Ontario. We actually also involved the Aboriginal Health Access Centre in Hamilton, Dodwatta, Desney. So the 2 studies that emerged from there were a study of Inuit in Ottawa and then First Nations in Hamilton. If you look at the top, you'll see the partnerships that we've built, so 7th Generation Midwives for Our Health Counts Toronto, and then the eagle is from the Southern Ontario Aboriginal Health Access Centre, and then you see the logos for the Aboriginal Health Access Centres in Kenora and Thunder Bay, which are underway. So I've already kind of hinted about some of the methods and key adaptations, so that we actually are applying principles of community-directed, in fact, participatory action research to health data collection, analysis, and dissemination. And actually the community organizations and partners are the data custodians, and they actually control the release of the data. So they're that band around the community in that figure I showed at the beginning about as we try to think about transforming data as a tool for community empowerment. We use Trocum and Kane's concept mapping as a way to ensure that our survey tools were actually reflecting correctly or to the best of our ability Indigenous concepts around health. And then another big innovation is we're actually using respondent-driven sampling, and I'm not going to go into details about respondent-driven sampling today, but just to say it's a pretty hot topic, I think, in a very useful tool in public health when you don't have a representative sampling frame. And then these tools, the respectful health assessment surveys. What's interesting is that came from the community, so some of you know about a rapid health assessment survey. When we were working on these survey tools, people said, well, you'll never get more than 20 minutes of our time. We found, because in our projects what we do is we transfer the funding to the community. We train community members to be the survey interviewers, and if you do that in the right way, people are willing to spend an hour, probably an hour 15. I'm a big advocate of data, but yeah, even Indigenous people, when you're being really nice, hit a wall in terms of questions. And then, of course, I've mentioned that we're linking with the Institute of Clinical Evaluative Sciences, and that's actually helped us validate some of the findings, which initially we were quite surprised, particularly the findings then about socioeconomic positions. Okay, so what have we found out from these studies? First of all, we've helped bridge this gap. So even though the majority of First Nations, Inuit, and First Nations and Métis, and a significant number of Inuit are living in cities, there was really a vacuum of health information about them. So now we have these comprehensive and inclusive data sets. So for example, there's over 800 variables in our Health Counts Toronto. And then we've actually been doing some analysis as well. So we focus primarily on just releasing the prevalence estimates for all of this information to fill the vacuum. It's a bit more complicated than standard data release and analysis. Even the descriptives take a bit of work when you're doing respondent-driven sampling. But now we're also, and have published some papers exploring links between, for example, multimorbidity and racism and unmet health needs. With the ISIS linkage, we're looking at factors that drive what we've found to be higher rates of emergency room use compared to the general like populations in the particular city and provincially. And then what the community wants us to do, of course, is to look at the positive and to look at understanding the links not only between what's driving these health inequities, but actually looking at positive health outcomes and what are some of the protective factors that can drive positive health outcomes. And then finally, as we get into the multivariable analyses, and with the support of Dr. Mike Rotundi, we've been able to work on methodologic refinements of respondent-driven sampling. One of the things that's always important, and many of you will possibly be thinking about this, but when we're in the middle of doing a big data analysis, each person in the study, and we have had over 2,500 people now across the province participate, is sharing their story, right? So from an Indigenous perspective, for me, from a Cree Métis perspective, that's actually a huge gift, and it comes with a responsibility to make sure that I carry that story well, and actually that it's not a waste of people's time. And so I put up that picture, and of course, those are my twin boys, probably about 9 years ago. So we should carry those stories forward and ensure we can make a positive difference for 7 generations. Another big thing, and so part of doing that is actually for me to work myself out of a job. And really, we do think that there's been a lot of opportunities, all of those community members that now are trained interviewers, many of them have come back and are working on our team now. So there's still a huge need, and that's one of the things I'm really interested in working on, putting in a very early grant proposal today. So we still are very short in the number of Indigenous people we have who are trained in quantitative methods, applied epi. So my goal is to work with you to train 100 of them in the next 10 years. Okay, so let's switch gears and talk about some findings, and I think I've already hinted, but one of the huge findings is just around population size. So like the recent Canadian census underestimated the size of the Indigenous population in Toronto by 2 to 4 times, okay? 2 to 4 times. That's, so instead of there actually being 19, just under 20,000, there's 55,000. Okay, so that's huge, and it has, as you all know, so here in Toronto, City of Toronto's been saying, and this is just the City of Toronto, not the GTA, has been saying, like Indigenous organizations have been saying for decades, that the census undercounts are huge, right? That there's 70,000 people living in the City of Toronto, but nobody believes the community. But now, so basically my day job is just figuring out ways to support people who don't believe Indigenous community or understand Indigenous perspectives to communicate that information in a way that they find rigorous and valid. And again, now we've replicated this finding. So the undercount was similar in London and also similar for the Inuit in Ottawa. So we found consistently, like I said, that less than 1 out of 5 Indigenous people is completing the Canadian census. And I think now that we have that in Ottawa, London, and Toronto, really you could be looking, and you shouldn't be, if you're looking at census data, you should just assume that it's at least 50% too low, right? So you should be at least doubling it. Here we go. So in case you just don't think I'm being outrageous and trying to keep you awake at your lunch hour, here is the article in the BMJ. Community organizations in Toronto, the partners, as you know, are Indigenous health service providers. But here in Toronto, actually, we supported that by a reference group that had over 20 Indigenous and allied organizations. Okay, so then here, what else about the determinants of health? So some of you might have seen the Toronto Star on, I think it was February 28th or March 1st. There was a front page story, pretty deficit-based, so my community partners and myself weren't quite thrilled with it, but just talking about poverty, homelessness, access to education, food, security issues, and employment, right? So basically all of these studies show like much higher rates of poverty than the census. So basically, and you can see that in the BMJ article as well. So I think what's happening is it's actually a subpopulation of Indigenous people in urban areas who are participating in the census, and there actually is a systemic bias in the Canadian census with respect to urban Indigenous people. Lightning did not strike me for saying there's a systemic bias. So those people who actually answer the census are more likely to own their home, right? And in that way, they're richer. So that we're actually finding these rates of 80% of the population living under the low income cutoff. Some people, if you understand respondent-driven sampling, we have some of the longest chains. So these are chains of like 26 people, and we can prove with our biostatistician that actually we're reaching equilibrium. And so you can actually look at the characteristics over time and see stability in terms of these estimates. So we have this strong evidence about underestimating inequities in the social determinants of health, and then we also found unacceptably high rates of racial discrimination generally and within healthcare context. With determinants, okay, we did that one. Okay, I think they're in usually I go, it's always a debate, but access. So with respect to health status and access to care, so given those social determinants of health, we found striking inequities in health outcomes across the spectrum of infant, child health development, adult chronic disease, mental health, and oral health. If you want to actually see, we released 26 fact sheets on February 28th. So if you just go to www.welllivinghouse.com, you'll see. But for example, rates of diabetes among a non-age-adjusted young adult population that are in the double digits, right? So I know when I was starting the study, my esteemed colleague Chan Shaw said, well, who cares if the rate of diabetes is 7 or 8%, right? But if it's 15% instead of 7%, then that's quite significant. And then huge rates of unmet health needs. So 1 out of 5, 1 out of 4 adults in these studies had experienced an unmet health need in the last 12 months. So 2 to 3 times higher than the general Canadian population. Gaps in access to screening programs, gaps in access to primary care providers for adults. We did a little better for children. And then multiple barriers in access to health services. And again then, just to try to not just build a completely deficit-based picture of what's out there, our study actually showed some amazing strengths in our communities. So those of you that know about respondent-driven sampling will know that they build on social networks. So it actually shows, and it challenges a myth, but yes, so for myself anyways, as an Indigenous person, my indigeneity is linked to where I'm from and who I'm related to, tied to land and tied to people and other in the natural environment. But these are some of the largest and most successful respondent-driven studies in the world. So what they show is we have these really strong urban networks that are incredibly resilient. So, and I am very fortunate. We've had it's a guy named Heckathorn that invented RDS. We've had 2 of his graduate students work with us. They're now at the Center for Disease Control. yeah, they were shocked at how fast our studies were going, and they're going that way because our communities are resilient, and we still have relatives, and we build kin networks in cities. Strong rates of Indigenous language use and a desire to pass it on to kids, a strong sense of cultural identity. So again, that's a myth that when people move to the city, they don't know who they are. We do know who we are. And then high rates of access and use to traditional foods, medicines, and ceremonies, and a desire for more access. Okay, so I'm going to drill down on a couple of findings, and then we're going to shift gears to evaluation because I want to make sure that we have a good quarter of an hour for discussion. So here we can just get a feel for it, and again, remember there's 800 variables, 26 fact sheets, but you see the young age. One of the interesting findings we found in Toronto is a large number of the adult sample identified as two-spirit, this high rate of people living below the low-income cutoff, but this high rate of people speaking an Indigenous language. And then extremely high rates of mental health issues, and so 45% having a mental health diagnosis. In my primary care practice, I do a bit of mental health and therapy, and there's just this huge gap in terms of actually culturally safe care providers. 53% have experienced discrimination because they were Indigenous, and again, we know this is an undercount because people are, one way of coping with discrimination is to not acknowledge it, but these are very high rates to be reported in a study. And then 38% didn't, so 1 out of 4 adults in Toronto who's Indigenous don't have a regular primary care provider, even though, the Minister of Health is currently trying to restrict the number. And then unfortunately, but not surprisingly, then we see that these inequities are transferred onto our kids. So first, great news, we also have 3 to 4 times in Toronto the children than the census is estimating, but food insecurity, 1 out of 5 households. And this has got to be an underestimate, right? Because over 50% of the families actually have child protection agency involvement. So then to tell even a community member that you have food insecurity would take a lot of courage. And that's just wrong. I'm sure all of you think that's wrong. That's why we're in public health, but kids shouldn't be hungry. Another strength here, 70% of children meeting physical activity guidelines. We know that transportation is a huge barrier to access, even bus fare. Toronto's a huge city, but yeah, one of the side effects is people are getting exercise. And then a huge burden around child development, disproportionate burden of chronic disease, completely avoidable gaps in access to immunization and dental care, barriers in accessing specialist care, and then this desire for cultural continuity. So in London, and again we got to thank Brian Dokas, the Executive Director of the Southern Ontario Aboriginal Health Access Centre, who gave me permission to share this, because we're the community release actually in London got postponed because of the election, so it'll be sometime in June. So this is very special because usually we don't like to release data until it's been released in the community. It's been shared with the board and their organizations. But again, 88% of the population living below LICO, and even younger population, huge language retention, but then these high rates of involvement, both in family of origin and current family with child protection agencies. High rates of mental health diagnosis, not quite as high in Toronto, makes us wonder if maybe there's fewer providers, because we also do screenings and we didn't find any lower rates. We screened for PTSD and depression and anxiety using a Kessler. And then 35% here not having a regular healthcare provider, so a consistent pattern that 1 out of 3 to 4 out of 10 people actually don't have regular primary health care, and then this high rate of being treated poorly by a healthcare provider, and then a high rate of having family who attended residential school. So overall, so what? So because one of the things is some people said, well, this is descriptive data, but I guess some of you might know when you actually produce data when there's no data, it is really intervention in my mind. Basically, we really hear from the community, so don't believe me, ask. We've seen this huge strengthening of Indigenous community leadership engagement and skills in population-based health assessment. Actually, the Duwata Desne Aboriginal Health Access Center now has this amazing Indigenous specific housing program because we showed that 13% of the adult population in Hamilton was homeless. That emerged right at a time they were about to cut the Indigenous specific homelessness funding. Instead, they increased it. Here in Toronto, we found out that 1 out of 4 adults is homeless or vulnerably housed. Again, both Hamilton and London say that their health access center budgets and services have dramatically increased because of this study. So the ED from Hamilton will say that her budget has increased 2 to 3 times. It's lovely because with that report, I'd walk around and see different staff members carrying it around. This exposure of the stats can undercount, which right away can translate into just if we're supposed to be doing needs-based funding, like the funding formulas have to change. And then the most recent success actually is $11.6 million of new funding for Indigenous child services here in Toronto. And then just because you should never believe a researcher when they say the community likes their research, here's some quotes from the community. Okay, so a bit of whirlwind information about health assessment, but I want to just take about 3 or 4 minutes and speak about health service evaluation. So as I mentioned, one stream of programming that we've also been doing is just trying to figure out this question, how can we decolonize evaluation? So I think many of you would have been aware before this talk about the OCAP principles, ownership, control, access, and possession as applied to health information. But what about health service and program evaluation? Many of you, again, are familiar with Indigenous and mainstream like program and service evaluation, often, you know, and probably too often in Indigenous health services, but I'm sure it happens across the board in public health. We have annualized program funding, and then like there's, if you're lucky, there's a little bit of money tacked on like at year end to do an evaluation, which you have to do and you won't get your money back. But in terms of the actual complexity and doing meaningful health systems performance assessment and feeding that back in, and then once we think about this idea, then okay, well, evaluation is generating information. How is the community involved in this evaluation? We need to kind of take a look. So we were lucky. We struck this 3-ribbon panel. So we, I think, sometimes call them blue ribbon panels. So a panel of experts, but different kinds of experts. Some you'll see on this slide, leaders in the area of public health. Everybody here, though, had drilled down experience working with Indigenous communities in evaluation, and then community service partners. And we asked for examples of the good, bad, and ugly Indigenous health program evaluation, and and then from that tried to see what kinds of principles emerged, and also what kinds of recommendations. So basically, like this notion of Indigenous governance, in fact, is very important as well to Indigenous evaluation, not just to Indigenous data, and a clear purpose. So what we found often happens in evaluation is it's actually about addressing a racist assumption that an Indigenous organization or community can't manage their money properly, right? But really masked as, oh, we'll try to do some service improvement versus make sure we didn't waste the money. So really the clarity of purpose, who wants to know and why, right? Indigegogi comes from Roger Boyer, and it's the idea that we actually want to think in an Indigenous way, a local Indigenous way, about the evaluation. Interrelationality is a foundational kind of knowledge, epistemologic concept in many First Nations, Inuit, Métis worldviews, but Marlene Brandt Castellano, who's like a preeminent ethicist and philosopher, described it once to me about the relationship between information points being just as important as the information itself. This idea about living a good life and holistic concepts of good living. I mentioned how the community is always asking me to balance out the deficit-based questions with the positive questions, flip the research question around so we can find out what are the things that drive good health outcomes versus what are the drivers of negative health outcomes. This notion of collectivity, it was just speaking with Peggy before the webinar. So I think in public health, that's a notion that will resonate for many of us. But if we look at research, yeah, often it's premised on still an individual doing all the work, senior scientists. So there's still quite some alive and well hierarchies. And then responsiveness. So we need to adjust what we do, right? So in Indigenous communities, there could be, we are having disproportionate mortality, for example. So, you know, if somebody dies in a particular Indigenous community, that's not the day that you're going to have your focus group, right? So you have to be flexible and responsive, right? If the Indigenous community is experiencing a housing or a food security crisis, right, then, yeah, don't be sad if nobody cares about your health service evaluation, right, or you have to build that in. So we were able to identify a number of WISE protocols, and I'd encourage people to have a look. We've also partnered with Public Health Ontario, and they have looked at the online literature, and then we came up with these guidelines. And unfortunately, due to time, I won't be able to drill down on them. But a lot of them would be, you can see the first one is about Indigenous leadership and a commitment to self-determination. It's tricky, right, because it's often the funder who funds the evaluation, right? So really being reflexive and thinking about how that power relationship may impact the results. So is it actually safe for the community to share things that could possibly be done better next time around, right? Or by doing that, are they going to actually risk the funding for that program? And as we know, you know, it's very interesting. I think about a year and a bit ago, I went to a small roundtable with Jane Philpott, and it was before health had been transferred over to Indigenous services. So I saw their strategic plan. And yeah, public health, they said it was not a uniform service, just meaning that not every Indigenous community would have access to public health. And I'm like, I'm sorry, I don't understand this. Like, we all have to have public health. Like, how can you even have this, right? Like, so they had services that were universal and services that were non-universal. So at that time, the federal government said that public health was a non-universal service for the subpopulation of people that FNIB actually tries to provide service to at that time. Okay, I'm not going to go into all the methods of our systematic review, but we also then, so we talked to experts with Public Health Ontario, and that paper should be coming out soon. We looked at the web, and then we also looked at the published literature. So I'm just going to skip right to the end here and just you'll see another set of Indigenous evaluation principles. Again, self-determination and the importance of balancing power relations right up there at number 1. So if there's one takeaway message, it's thinking about how you can do that in your work. Foundational integration of Indigenous knowledge and practice. We had the Indigegogi. So you can see that there is quite a lot of synergy between these different principles and recommendations. We've also developed a course, which we hope that we can offer soon. And I did manage to make it through, I think, with 11 minutes for questions and discussion. So I will turn it over to whoever is going to help facilitate that.
Thank you, Janet. You've just given us so much to think about. There were a couple of questions that I think it would be helpful for you to address. And one of them referred to something you talked about in how do we frame reports around Indigenous health so that it's not always deficits?
I think the framing then has to come before the report stage, right? So that, because if you're going to share a balance of information, then in theory, you're going to have to be working on that in your data collection process. But having like Indigenous people in your working group, but who are paid, right? Like, don't assume because there is these workforce issues, right? Or so they have a role that's been formalized and that they are remunerated for, which is actually to support a balance. the very first thing I wrote, the Guide for Healthcare Professionals Working with Aboriginal People, the advice I got, so there is a large group of people who helped me with that, and they said, you know, somebody said very nicely, if you're going to write something negative, balance it out with something positive. So I don't know that I ever achieve it, but I try to always keep that in mind in my writing. And I try to pass that on to my students. So it's kind of like in theory, you should be balancing the negative with the positive. So it takes a bit of a critical lens, though. So I find that some of the Indigenous people will know and already be doing that, or other allies who have thought reflexively. But, you know, we're trained by the media to have pictures in our head, right? Like when we think Indigenous, we think something negative. That's what we talked about at my last talk. So I think having, if you don't have lived Indigenous experience, thinking about finding somebody that can help you out with that.
Super. Another question was, are the list of survey questions available? And sort of going along with that, were the same questions asked in each city, or were the questions developed by the community in that city?
So both. First of all, yes, the communities own the survey tools. If you want to see an example, you can just Google Our Health Counts First Nations Hamilton, and the survey is actually attached in the report. I think in the Inuit report too, the survey tool may be at the back of the report. If it's not at the back of the report, it will be online. And then with Our Health Counts Toronto, I have to double check, but you can certainly get because the community owns it. But I think they were waiting until the data was released. I would say that over time, because we've been doing these surveys now, like Our Health Counts is about a decade old. So we did our first data collections in 2009, 2010. So over time, we've been able to evolve and improve some of the questions. But yes, I would say about 70% of the questions overlap between the different studies, but that we customize it with every community. And the way that the survey is framed varies with every community. So there's been there's been an extensive process of local community adaptation. And we go through every question, right? Because there's always a trade-off between using a tool like Kessler, right, using questions that are on the Canadian Community Health Survey, because then you can do comparisons with trying to get at something like, well, what is a question about resilience in the face of trauma, instead of just asking about childhood trauma. So we had to look all around the world for that one, and we found a growth and empowerment measure. So we'll add a couple new questions to each survey that respond to local concerns, and then we can continue to refine and do some validity checks and see how they hang together once we're completed that study.
Thank you. Dryden's asking, do you know when the reports from the other communities will be released?
Yes, so Our Health Counts Toronto, Julie, thank you. You put up the fact sheets. I believe that if you just type in Our Health Counts Ottawa Inuit, the report should be online at Tunga-Savinga Inuit. If it's not, let me know, and I'll work with the community. And Our Health Counts First Nations Hamilton has been released. And like I said, Our Health Counts London was to be released on May 8th, but unfortunately, because of the provincial election, that's been postponed probably till sometime in June.
They're looking for the Thunder Bay and Kenora results.
Yep. Well, so like I said, it's an intensive process. So we're just in the process of refining the survey tools with Thunder Bay and Kenora. That'll probably take us up until August. Then we have to program the survey into computer-assisted web interface, train the local interviewers. So Thunder Bay and Kenora, if you want data, now's the time to get in touch with the respective health access centers and tell them what your burning questions are. But the data then, it'll take us 8 months to a year to collect the sample, because we've got to find a sample of, and we can't control that. It depends on how quick it goes. So unfortunately, we won't probably have the results for Thunder Bay and Kenora for about probably another 18 months. But now is the time to let them know what data you need.
Good point.
And I guess I feel like it is a long process, but given that we've been living with no data, like a vacuum, yeah, hopefully 18 months won't be too long.
There is a question about what was in the survey that helped to determine resiliency. Questions about that.
So like I mentioned, in Toronto, we used a tool called the Growth and Empowerment Measure. So actually it's a tool called the GEM, had been developed and validated in partnership with Aboriginal communities in Australia. We can also ask questions like about resiliency. Of course, we ask questions about language use, the importance of cultural continuity. One thing that's amazing is actually how well people report like self-rated health, given when you start looking at like living under the low income cutoff. I think I'd be pretty miserable if all of a sudden I was shifted to living under the low income cutoff. But yeah, people's self-rated health, like there's way lower rates than, so they're much more resilient than me. To me, getting traditional foods, so over half of the Indigenous community in Toronto had used traditional foods in the last year. And in this context of high rates of food insecurity, to me, that's like a huge resiliency. Yeah, those are just some examples.
Two people have asked how they can access the iHike course.
So yeah, that's something that we should try to work together in partnership. So what we did is we developed it. We piloted it actually with a network of Indigenous health service managers, many of whom are also partners in our health counts. So yeah, if there is somebody that has capacity to actually kind of support the next step, then that would facilitate the access. We need funding and great people that can just take it. Well, we just called it, actually, it does have a name, but we gave it an Indigenous name, but I don't think I have that on the slide. But Elder Jeannie Herbert gifted us with a beautiful name for the course.
And the burning question that is on many of our minds, if we're interested in having our health count survey conducted in our area, what would the process be?
Talk to your LINs and then tell them that the technology is there. It costs about $600,000 to $1 million to get it done, and then we also need more Indigenous epidemiologists to help us with it. So yeah, it's just a balance of resources, funding, and capacity. So yeah, talk to the LINs, talk to your public health team. So for example, we still have data from the existing Our Health Count survey that we haven't been able to analyze yet, and I think we're working on a partnership with Ottawa Public Health so that one of their epidemiologists can actually help us with the child health data, which, so when we started, yeah, we had, we were way under-resourced. We have one full-time biostatistician, like master's trained biostatistician, who's excellent on our team, right? So we're constantly hugely under-resourced for the work.
So if someone could ante up an epidemiologist, they wouldn't necessarily have to be an Indigenous person, but would have to use the principles and work with your team. Is that right?
That's right. And then we would have to work with the local partnerships. It depends. Like the epidemiologist can help with the data analysis, but actually building those relationships, like building survey tools that reflect local Indigenous knowledge and practice, that requires somebody who's had significant life experience or 5 to 10 years of like focused work, I think. It really depends on the person. But like I've said before, one of the most common errors we make is it'll be easy to do this stuff, right? But I'm saying I'm Indigenous for 50 years, and I've been doing this for my whole career, and I still get it wrong in terms of the balance with the community of the survey tools. So, yeah, it's an awesome area. So, yeah, I would say that part of what I would like, that's why I want to have 100 Indigenous people trained to do this work in the next 10 years. But see, I think non-Indigenous people or people who are like serving like diverse populations, so I don't expect everybody just wakes up every day and wants to do everything Indigenous, they could play an important role like in mentoring and supporting people in finding the resources and the funding and partnering like with others.
Okay, I see we're at 1:01, and I was told that we only had till 1 o'clock, so I'm going to wrap us up here. I want to thank you so much, Dr. Smiley. This has been a wonderful insight into Indigenous evaluation principles, into hidden issues that we didn't necessarily know about, because once we got that census, everyone was excited that they had some data. But clearly it's not the whole story. So we appreciate you coming and sharing this information. I know it will be helpful. We'll all go away and think about how we can apply the Our Health Counts information and the evaluation recommendations. I know our health unit actually has formed a little group to talk about doing research and evaluation with Indigenous populations. So I also want to take the time to thank everyone on the line for your attention and the good comments and questions. Thanks, Dawn, for answering some of those questions, for people chipping in. And I believe there will be a feedback survey on this webinar. I'm not positive on that. So if you get one of those in your email box, please fill that out. Do you have any last comments to make, Dr. Smiley?
No, just I'm very grateful for the opportunity. I know it was a lot of information, some at a very high level, but the questions are very good, and I look forward to ongoing collaboration. So, and I hope everyone has a nice day.
Thank you, and goodbye, everyone.